Can we start?
Yes, ma'am.
Okay.
So, good evening, everyone, to another interesting session of the webinars of which thyroid clinics, which are organized by the Indian Thyroid Society under the leadership of Dr. Sarita Bajaj. So, we just a brief about our society. It was established and registered in 2003, and it is basically a national body of healthcare professionals with special interest in thyroid disorders. And many of the specialities are a part of this society, including the endocrinologist, endocrine surgeons, nuclear medicine physicians, general physicians, even general surgeons and ENT surgeons. So all of you can become a member of the Indian Thyroid Society. And ITS is a member of Asia-Oceania Thyroid Association also. And it has around 2,000 members. Our founder president is Professor R.V. Jayakumar sir, and our present president is Professor Sarita Bajaj ma'am. And she is coordinating the thyroid clinics at the moment. And our EC have our past president is Professor Rajesh Rajput, and our secretary is Dr. Arun Menon, and treasurer is Dr. Mini Pillai. And we are all part of the scientific committee and executive committee as well. So vice president is Himagirish Rao, and I am the scientific coordinator for this. And joint secretary is Dr. Sujay Ghosh. Dr. Sashank Joshi is also our EC member. Dr. Jabbar is also our EC member, and Dr. Krishna Shishar. Dr. Mohammad Riaz, Dr. Sushil Gupta, and Dr. Ashraf Ghani are also part of our EC. The aims of our society is basically to organize academic activities for healthcare professionals, which we are regularly doing, to promote also public education, which is our motto, and awareness about the thyroid disorders, and also to encourage research in thyroidology, for which we grants, and we advertise our grants in between whenever the session is there for the grants. And we encourage publication in our flagship journal, which is Thyroid Research and Practice. Just to add that this is our society journal, so please send your articles to this journal, which is taken care by our society, and it is a society journal which is managed by the Indian Thyroid Society members. And we also have the award fellowship of the society, which is going to come soon. And we encourage everybody to become a member of our Thyroid Society. We also have ongoing academic activities in the form of CMEs, updates, symposia, and conferences. We are doing this clinics, which are called as thyroid clinics. Presently, we are doing it fortnightly. Previously, we were doing it weekly. And most of the DM residents are actually attending these clinics, and we have a good attendance in these clinics, and people actually are very much interested, and we all enjoy these clinics. It comprises of journal clubs, case conversations, and monologues and duologues, panel discussions. We have meet the professor sessions also in between. We have very interesting quiz in all these clinics and workshops, as well as CPCs whenever the time comes for that. And we celebrated from May 22nd to 28th the Thyroid Awareness Week, on 25th as the World Thyroid Day, and we celebrate Thyroid Awareness Month annually in January. And we, as I told you, the ITS provides annual grants for original research studies which are focused on thyroid and related disorders, preferably in the Indian context. And you can access our website, which is www.indianthyroidsociety.in, and you can take the details from there. And not to forget, again, our journal, which is published twice a year in print and online. And we encourage everybody to send your articles to Thyroid Research and Practice, because it is the journal of the Indian Thyroid Society, and electronic copies are available ahead of print. And fellowship is one thing which Madam has started, which is to be awarded to ITS members with expertise and experience in the field of thyroidology. And the selection will be done by an expert panel, and eligible members will be conferred the Fellow of the Indian Thyroid Society. So this is our manual, which was last in our thyroid conference, like 4 years back, it has come out. And now we are coming up with the other manual, which is the review of that. So this was the initial one, which was the first edition, but we are also coming up with many guidelines. So we are going to soon come up with thyroid dysfunction pregnancy guidelines for management of pregnancy and thyroid, and also hypothyroidism and diabetes and subclinical hypothyroidism, all are coming soon. Few of the guidelines are already available, and few of the guidelines are going to come up. We are going to do some modifications and update the guidelines, and upcoming guidelines are going to come on management of subclinical hypothyroidism, thyroid disorders in pregnancy, and management of thyroid carcinoma. So, and as I told you, our clinical manual of thyroid disorders, second edition is just coming up. We are just in the thing to make it, and all the people are just sending their chapters, and soon it will be, Dr. Sarita Bajaj ma'am is coordinating it, and soon we'll be having it available for the members. So these are the links we can see. You can go to the website. We have the link to the guidelines. We have the link to the ITS journal as well. We have record of all the academic activities, as well as there is an online membership portal through which you can become member. And now it is very easy. If there is any problem, you can just send a mail and it will be done for you. But most of the times it is very easy now, and you can just get this online membership, and you just pay and you can become the member. And all MCI registered modern medical practitioners in India are eligible to become life member. There are two types of life membership. One is a full-time membership, which is for the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine. And then we have an associate life membership, which is for all other registered medical practitioners. And the decision of the board is the final for giving the membership. And applications are invited online on the ITS website for the membership. As I told you, it's available. You can just access our website and you can get the link to the membership and you can become a member. So with this, we start our first session. I think Dr. Rakesh Sahay sir is yet to join. So
I think we'll carry on. We just have to.
Yeah. So we have an interesting case discussions lined up with a very interesting quiz also coming up. So I request Dr. C.M. Batra to start the proceedings, who is the moderator for the first session. He is a senior consultant endocrinologist at Indraprastha Apollo Hospital, New Delhi. So he'll be taking us through the first case, and Dr. Sumaya will be presenting. Dr. C.M. Batra will introduce her, and then we'll go on to the next case.
Thank you, Dr. Pamda Kalra, for the kind introduction. Thank you, Sir Sarita, for inviting. And we have a very talented young.
So interrupt, Dr. Rakesh Sahay sir has joined, so he can also be.
Just introduce him, yeah.
Yeah. So I think Dr. Rakesh Sahay sir, we all know Dr. Rakesh Sahay sir, so no student needs introduction of sir. So he's our chairperson for today. He's the professor and head of Department of Endocrinology, Osmania Medical College and Hospital. And he has around more than 150 publications in various national and international journals. So he's the president of the Endocrine Society of India and vice president of the South Asian Federation of Endocrine Society. So I welcome you, sir. Sir, we can take over the process and we can.
Thank you, Dr. Pramila, for the kind words of introduction. And I would like to congratulate the Indian Thyroid Society under the dynamic leadership of Dr. Sarita Bajaj for conducting these thyroid clinics, which have become, I think, very popular amongst the entire medical fraternity of the country. And I welcome everyone who has joined today to this interesting webinar, which is going to be again the next in the series, which is going to discuss two interesting two interesting presentations are going to be. The first presentation will be a set of cases, and there's another presentation, and as usual we have a very interesting quiz, and I'm sure everybody is waiting to take part in this. So with these words, I would like to ask the moderator for the first session. I think Dr. Vaishali Deshmukh is here. I would ask her to give a few words before we ask the first presenter, Dr. Sumaya, to present her cases that she's.
Dr. Batra is doing the first.
Dr. C.M. Batra is the moderator for the first session.
Okay, Dr. Batra is, sorry, I'm extremely sorry. So we have Dr. Batra with us. I think he has been introduced. He's a well-known figure in the field of endocrinology and he's practicing at Delhi, and Dr. Batra will take over the proceedings from.
Thank you, Dr. Rakesh Sahay.
Yeah.
And we have today a series of cases from Osmania Medical College, presented by Sumaya, who's a second-year resident in PNP resident there. And the plan today is that she has around 6 cases. So after every case, we'll have discussion from the audience, from the faculty. Sumaya, please carry on.
Yes.
Thank you so much, sir. Am I audible? Are my slides visible?
Yes,
you are audible.
Thank Thank you. A very good evening to one and all, respected faculty and dear colleagues. Today I'll be presenting on atypical presentations of hypothyroidism, which was seen in our department. So coming to case one, an 11-year-old girl who presented to pediatrics with lower abdominal pain for 2 days duration. And on evaluation was found to have bilateral multiple large-sized ovarian cysts and was referred to gynae oncology. So there she was found to have elevated tumor markers, and in view of the bilateral complex cyst, she was planned for surgical management in view of a suspicion for malignancy. However, as a part of pre-op evaluation, she was found to have deranged thyroid function test and short stature, for which she was referred to us. On further inquiry, her mother reported decreased height gain over the past 2 years, and that breast development had started at around 7 years in the child. And there were 2 episodes of vaginal bleeding 2 months apart, which occurred at the age of 8 years, for which they actually did not seek any medical help. And there was no history of pubic hair or axillary hair development. And history for other etiologies for short stature were negative. Past history and family history were non-contributory in her. And on examination, she had pallor with vital signs were stable. She had dull-looking coarse face sheets with generalized dry skin and pseudohypertrophy of calf muscles. She also had grade 3 acanthosis nigricans. And anthropometry revealed a height of 123 centimeters with a height SDS of -3.2 and a weight of 36 kg between 10th and 25th centile. So height age was less than weight age, and upper segment lower segment ratio was 1.08. Sexual maturity rating revealed P1, B4 with absent axillary hair, and systemic examination was unremarkable except for delayed relaxation of deep tendon reflexes. So investigations revealed nomocytic anemia with hyperlipidemia, elevated CA125, and gross elevation in the TSH with suppressed T3 and T4. And her born age was in the range of 7 to 8 years. So ultrasound abdomen and MRI pelvis, which is done as a part of oncology workup, showed bilateral cysts in the ovaries measuring 10.6 into 7.8 centimeters. And there were features of hemorrhage in the right cyst as well. And MRI brain was suggestive of pituitary hypoplasia. So her final diagnosis was primary hypothyroidism, juvenile onset with short stature, gonadotropin independent precocious puberty, isosection, pituitary hyperplasia, and nomocytic anemia. So, and as part of management, she was started on a 50 microgram levothyroxine once daily, and the dose was up titrated by 25 microgram every 2 weeks, and to reach up to 100 microgram and continued. And the review after 3 months revealed regression in size of the ovarian cysts, and surgery was thus avoided. And at 1 year, there was complete regression of ovarian cysts, and her height gain was 7 centimeters. So this is her initial picture, and this was a picture taken after 1 year. So the aspect to be highlighted in this case is a phenomenon known as Van Wijk-Grumbach syndrome, of which I would like to explain the mechanism. But after the second case, because that is a similar phenomenon which happened in a male child. This 8-year-old boy came to us with history of poor height gain and delayed milestones since 3 to 4 years. Both his birth history and past and family history were non-contributory, except for the fact that he had delayed milestones and poor scholastic performance. And anthropometry revealed a severe height deficit with a height SDS of -6.9 and a weight SDS of -2.5. And general examination revealed pallor, and again his height age was less than weight age, and he had disproportionate short stature. So we can appreciate all the features of overt hypothyroidism in him with coarse facies, dry skin. He had abdominal distension and umbilical hernia, and he also had calf muscle pseudohypertrophy. He did not have any goiter or signs of malnutrition. The thing that we noticed in him was that he had enlarged testicular volumes. So the right side it was 5 ml, and the left side it was 6 ml. So that was actually not noticed by the parents. Investigations revealed anemia with TSH of more than 150 and T4 of 0.3 microgram per deciliter with a delayed bone age of 1.5 to 2 years. So in him, the final diagnosis was juvenile onset hypothyroidism with short stature and macroorchidism. So for him, the requirement as per body weight was 4 microgram per kg, and he was started at a lower dose with gradual up titration. So coming to, with these 2 cases, we would like to discuss the pathophysiology of Van Wijk-Grumbach syndrome. So it is mainly explained by the specificity spillover, that is cross-reactivity of excessively high TSH on the ovarian FSH receptors, leading to follicular maturation, multicystic changes and estrogen production in females, and testicular enlargement in males. So the other mechanisms postulated are because of the decreased feedback inhibition, TRH is increased. So TRH mediated excess prolactin production leads to the slowing of GnRH pulse frequency. So this leads to an increase in the FSH production, but not in LH. And again, there is decreased clearance of FSH. And fourthly, there is an increased sensitivity of the ovaries to the available circulating gonadotropins that results from a hypothyroid state directly or due to increased prolactin. And lastly, it could be due to a myxodematous infiltration of the ovaries or the testes. So these were the mechanisms I could find from the literature for Van Wijk-Grumbach syndrome. Hence, the learning points would be the presence of a delayed born age in patients with precocity is an important clue for this phenomenon. And early recognition and initiation of thyroid hormone replacement causes reversal of all symptoms. And this avoids further diagnostic tests, fear of malignancy, and unnecessary surgery in these patients.
So let's stop here.
Yes.
And let's have a discussion on this. Now, this is a very interesting, these are two very interesting cases of this Van Wijk-Grumbach syndrome. And what is important in them, there is precocious, some elements of precocious puberty. It's actually a pseudo-precocious puberty because the pubic and the axillary hair don't develop. Only the breast development is there, and bleeding is there because of estrogen production by the cysts. So, and the one thing that I want to discuss is that this practice of starting thyroxine in a very small dose and then increasing, this is actually very controversial, and I want to hear the faculty's opinion on that. So, Dr. Kalra, what do you think about that?
Yeah. If I may just add in, Dr. Pramila is here.
So you add your point first. You are the
Go ahead.
Yeah. So this is a scenario where unlike the garden variety of hypothyroidism, where we would like to start off with the full replacement dose, and we would certainly do that in all such situations. But here we have a long-standing hypothyroidism. These children have been having hypothyroidism for a long period of time, and then this is a scenario where if we start a higher dose, they end up with problems like benign intracranial hypertension, and so these are situations where we would go with a smaller dose. Apart from we have elderly people with cardiac compromise, you would start with a smaller dose. This is another situation where I would prefer to start a smaller dose and gradually increase the dose rather than give the full replacement dose. Actually,
Dr. Sai, I also thought like that, but when I reviewed the literature, there are some papers which say you start with a full dose. Some say start with a small dose. So I wanted to know what the faculty thinks.
Let's take the opinion about this. But the controversy is obviously there. But I think this is a scenario where we can have these problems with the full replacement dose. Yeah, Dr. Kalra, Dr. Pramila.
I see that. I think last time also, Pramila, didn't we have some similarish case?
Yes, ma'am. Yes, ma'am.
Pediatric endocrinologists were
ma'am.
very clear on that. What they would start slow and step up slowly as well, because of the reason which Rakesh has mentioned, apart from hyperkinesis. So they also, that was one other reason that they said. So I think this was the consensus or the take-home message, right? Isn't it?
Last time we discussed this point. Yeah. Yes, ma'am. This was a point which was discussed, and they were also of the same opinion. That that's as I said, this is still a debatable topic. We can still debate on that. But the thing is, it's like both schools of thought are there, and both the literature says both things. And we have to decide, I would say, on an individual basis. Like sometimes we know that the patients may not follow up so much, and then we might start a higher dose and send them, because sometimes we want them to take the treatment, and because sometimes we have patients who come from very far off, they may not report again, and we are worried. So they may not come for 1 year or so. So then we are worried, and then we start off. But obviously, if there is a follow-up which is expected to happen, then it's okay. Then it's the wise decision to go a bit slower. And if they understand, because sometimes they don't even understand how to take, and they get very confused. So we say, okay, you give this dose, at least the thyroid will be treated. But as ma'am said last time, there was similar discussion happened, and then the pediatric endocrinologists were in favor of the dose, as Dr. Sahid said. So it's all It's a debatable topic. I think we can have a debate on this in one of the thyroid clinics, ma'am.
Yeah.
The crux of the crux here is how long standing the hypothyroidism.
Yeah.
If you're sure it's not very long standing,
then you
can start full dose. But if it is long standing, then it is recommended to go slowly. So you can also start full replacement, she said. But then you have to decide in which set of patients.
Yes.
Yeah, the bone age here and then the TSH level are
long standing.
Yeah, are the indicators here of long standing nature. Of
second thing let's discuss is I want to ask this question to Sumaya. How do you differentiate pituitary hypoplasia from pituitary adenoma? Your picture there in your case showed pituitary hypoplasia. So what were the distinguishing points?
So pituitary hyperplasia usually will have a dome-shaped convex upper border, and it will not invade the surrounding structures. There will be no paracellular extension, and there will be no enhancement in T2, unlike adenoma, which will show enhancement.
Yeah, it's absolutely homogeneous.
Yes, sir.
So, any other distinction?
Yeah, one more question for you. So, like, of course, the ovaries in the follow-up. So the ovaries regressed, and did the testicular volume also come down?
Yes, ma'am. Actually, the boy we saw a little recently, so he's yet to come back for follow-up, actually, ma'am.
Okay.
We saw him.
I'm sure that would also regress, because the volume should come down.
Yes.
And of course, that is very interesting, that pseudohypertrophy. But is there any objective, or it's just a visual impression? Is there any objective criteria for that? Just wondering.
Not that I'm aware of, ma'am. In view of the other clinical findings like delayed relaxation of ankle jerks, I mean,
the pseudo-hypertrophy. Delayed relaxation is part of the hypothyroidism, which we used to, I think we were taught photomotograph. We used to be taught about that, but no longer practiced. And I don't think much in practice then also. Anyway, I think we'll go ahead. Sorry, Dr. Batra, please.
Yeah. So, this is a very interesting case, and of course, and a very rare case, of course. And this delayed bone age, how long does it take to to improve?
Sir,
hello.
Yes, sir. Usually, when we start treatment, there is a initial acceleration in the bone age, actually. But for it to depends on how long standing the hypothyroidism is. If it's maybe more than 5 to 6 years delay is there, it will gradually maybe normalize in maybe the next 3 to 4 years only. So, but initially an acceleration in growth and epiphyseal maturation may be observed.
Okay. So, any of the faculty have any questions? Please ask.
I think we'll move on, please.
Okay. To the next case.
Yes. So coming to case 3, who is a 30-year-old gentleman who presented with history of insidious onset, gradually progressive breathlessness with acute worsening for 1 day. And there were no other history pertaining to the cardiac or respiratory system. And past history was diagnosed to have hypothyroidism 2 years ago, for which he took treatment and then defaulted. And there's no history of any other illness in the past. And he's a reformed smoker with a smoking index of 48, and family history was non-contributory. General examination, he had mildly pitting pedal edema with stable vital signs at the time of examination. He had elevated JVP, and there were no goiter or autoimmune features or stigmata of tuberculosis or xanthelasma or xanthomas. And CVS examination, apical impulse could not be visualized or palpated, and there were muffled heart sounds. Other systems were unremarkable. And his chest X-ray actually showed a large cardiomegaly with a cardiothoracic ratio of 0.76 with a large pericardial effusion, the typical water bottle sign that is traditionally been taught to us. ECG showed low voltage QRS complexes. There were no signs of infarction or ischemia. And 2D echo showed a large pericardial effusion with a severe LV systolic dysfunction with an ejection fraction of 34%. There was no regional wall motion abnormality. So we can see that his TSH was 120 and T4 and T3 were low. And pericardiocentesis was done for both for therapeutic and diagnostic purposes, and the infective etiology was relatively ruled out, and even the autoimmune markers were negative. So the final diagnosis was that it was a large pericardial effusion without any evidence of tamponade, heart failure with reduced ejection fraction, and patient was in sinus rhythm, probable etiology being hypothyroidism. And heart failure improved with pericardiocentesis and diuretics and supportive treatment. So in view of his cardiac failure as well, he was started initially on a small dose of 25 microgram per day and gradually up titrated. And review visit after 2 months showed that the patient was clinically asymptomatic with no reaccumulation of the pericardial fluid, and the TSH had reduced to 28 milli-international units per liter, and this was his follow-up X-ray. So pericardial effusion hypothyroidism is about 3 to 6% in mild cases and 30 to 80% in severe cases. And what is the learning point here? I would just like to explain the mechanism which is attributed to it. So it is mainly attributed to increased vascular permeability to albumin and not due to accumulation of mucopolysaccharides as causing water retention as the usual pathology. So in hypothyroidism, there are 2 points here. One is increased albumin permeability of the pericardial capillaries, and next is decreased albumin drainage into the lymphatic vessels, which ultimately increases the pericardial space colloid pressure and draws fluid into it. So this is a picture of the normal pericardial space, and the green one shows the lymphatic vessel, and below we can see the pericardial capillaries. So normally only around 5 ml of pericardial fluid is maintained because of the balance between the pressures. And here, because of the increased permeability of albumin and decreased uptake, it increases the osmotic pressure and draws fluid into the space, causing effusion. So the blue molecules are actually albumin. So why the increased permeability to albumin? So it is postulated that low thyroid state could really cause mastocytes to release histamines, or it could directly affect the endothelial layers. And the lymphatic drainage could be impaired because of pulmonary hypertension that is caused because of impaired smooth muscle relaxation that is induced by hypothyroidism. And again, because of the decreased sensitivity of circulating catecholamines, whose role is to increase the flow of lymph. So, and is there any role for autoimmunity? The available literature says no. In pericardial effusion due to hypothyroidism, there is no role for autoimmunity. Learning points, many cases of pericardial diseases are due to hypothyroidism. They are missed because of lack of TSH testing. So every patient with an unexplained pericardial effusion should be tested for hypothyroidism because it is an easily treatable condition.
So Sumaya, it's a very interesting case. Thank you. And let's discuss one thing. What happened after the pericardiocentesis? Did you do the echo again? What was the ejection fraction then?
Sir, yes, sir. After the pericardiocentesis, the ejection fraction actually improved, not to the normal limits, but improved to around 42, sir. But then at follow-up, his echo had actually showed normal systolic function, sir, after 2 months. Okay.
And here again, in this case also, pericardial effusion, the various cases that we saw in the literature, some say that you go ahead and give the full dose of thyroxine. Some say that you start with a lower dose. There's again a controversy. And there are some cases in which they were even given IV thyroxine. So what is the opinion of the faculty from this?
Can't mute. Rakesh, you are mute.
Yeah, let's take the opinion of Dr. Vaishali Deshmukh.
Hello, Vaishali.
Good evening, sir. Good evening, everyone.
Good evening.
Yeah, I think I agree with slow up titration of thyroxine in cardiac patient and in patients with short stature also, because there is a fear of stunting of growth in short statures with rapid correction. And secondly, there is a chance that the cardiac dysfunction, either an arrhythmia or the tamponade, might really worsen. Especially I've seen that tachycardia worsens significantly. Ischemia may be one of the manifestations of rapid correction. One thing I would just like to add to the case which Dr. Sumaya has mentioned, that I've seen 2 cases of hypothyroidism coming with pericardial tamponade, and we thought that it was related to hypothyroidism, but both turned out to be tuberculosis. So we should not forget that tuberculosis is very common in thyroid patients. I don't know, somehow there is a relation where we see a lot of TB, lymphadenopathy, as well as
tuberculous pericardial effusion, and one was a case of Turner's with hypothyroid with pericardial tamponade, and the other was a patient who was diagnosed as thyroid CA, became hypothyroid, and was found to have pericardial effusion. So we may not always put it into one picture. We may also need to think of a separate differential for the pericardial effusion.
In fact, Vaishali, when Sumaya said idiopathic, I was going to say in India, they would have put the patient on
AKT, yes,
without thinking twice. Definitely. I remember a referral from an OBGYN for a patient who was having menorrhagia. I mean, like she just did not, just pouring blood, and they were going to do hysterectomy, all set to do a hysterectomy. She also had a pericardial effusion, which the cardiologist was treating. Fortunately, somebody got it into their head too, and she was grossly hypothyroid, long-standing hypothyroidism, and just see that one tablet can do wonders. Everything. She didn't need any surgery. The pericardial effusion melted away, and now I'm talking about 2 decades back. So with hypothyroidism across the lifespan, across the presentation, even in overt, the presentations can be so variable that sometimes because as specialists, we get referrals. So we are lucky to not mostly, have it on a silver platter, isn't it? The question is, when you're a physician and then you're not, it's difficult. I'm sure it could be difficult in some cases, isn't it? Yeah.
So I just wanted to add to the previous case that short stature with severe hypothyroidism can come in a female with an ovarian cyst, and most of the time the ovarian cyst is removed for no reason before treating hypothyroidism. That's a common error that I come across in private practice. Yeah, and I think that's a very brutal thing to do for a patient with short stature.
That's exactly what the presentation was. In fact, the confounding factor was a high C at 125 also. So that was actually prompting them to go for surgery, but we stopped them from going for surgery.
Dr. Deep Datta has reported this also. Same, going in for malignancy, high CA. So I'm just, is there any literature in that context, Sumaya, regarding the high CA in association? There is.
And I actually went through a few case reports. Actually, one reason is due to delayed clearance of the tumor marker because of hypothyroidism, and another is that benign ovarian cyst per se can produce CA125. So those are the postulations given, ma'am.
Yeah, so the ovaries out is like miserable.
Sumaya, there's one more question. Now, what is the surgery that is done without treatment of hypothyroidism in a hypothyroid patient? You remember? That usually all patients were put in for surgery. If they have hypothyroid, the hypothyroidism is corrected, unless of course it's an emergency surgery. But there's one particular type of surgery which is done without correcting hypothyroidism.
Cardiac surgery.
Yeah. Dr. Saya is right. This is the only surgery which is done. In fact, they say that if you start thyroxine before the surgery, you might have introduced angina and myocardial infarction. So let's go to the next case. There's no more question.
Case 4 is that of a 19-year-old nursing student who presented with a milky discharge from both breasts for 3 months. That was her sole complaint. And there was no history of any lump in the breast or any drug intake. Menstrual cycles were regular, but she also had holocranial headache without any aura, photophobia or phonophobia, and there were no visual disturbances. On further inquiry, she had dryness of skin and constipation for the past 5 to 6 months. And this was a picture. And otherwise, her examination was unremarkable, except for the expressive galactorrhea, which is present bilaterally. Breasts were otherwise normal. There was no lymphadenopathy. And she had no obvious features of hypothyroidism. Visual fields were also normal. So the differential diagnosis we entertained were drug-induced hyperprolactinemia, primary hypothyroidism with hyperprolactinemia, or a rare possibility for prolactinoma clinically. So biochemically, she had a TSH of 150 with a T4 of 3.4 microgram per deciliter, and prolactin was raised to 55. And ultrasound breast showed no evidence of mass. And hence, the diagnosis was primary hypothyroidism with hyperprolactinemia as the sole presentation. And an MRI brain, which was done, showed pituitary hyperplasia in her. So she was started on 50 microgram levothyroxine once daily, and follow-up after 2 months showed that the TSH decreased to 6.8, prolactin decreased to 15, and clinically the galactoria had resolved completely. So this is a next discussion point, that is hyperprolactinemia. So the prevalence of the hyperprolactinemia is 20 to 30% in hypothyroidism. However, clinical galactoria was reported to be only 1% as per an Indian study. And so what are the mechanisms? So we all know of the first mechanism, that is low levels of free T3 and T4 reduce the feedback inhibition of TRH. So that causes stimulation of prolactin secretion, one directly by activating TRS receptors on lactotropes, and secondly, indirectly by regulating dopamine secretion from the hypothalamus. Now, there are other reasons also which I could find from the literature. One is that there is reduced sensitivity to the dopamine's effect, inhibitory effect on receptor and post-receptor pathways. And T3 per se is known to be an inhibitor of prolactin production. Like in animal studies, it has been shown, and low T3 hence will lead to more prolactin synthesis, and prolactin clearance from the circulation is reduced, and a stalk effect because of the pituitary hyperplasia can also cause hyperprolactinemia. These are the other mechanisms. So hence, galactoria with pituitary mass need not always be caused by a pituitary adenoma, and a primary hypothyroidism should always be ruled out. This is fully reversible with thyroxine therapy, and patient reassurance is very important here.
So this is a very simple case, and let's see if there are any questions from the faculty or the audience.
The learning point here is the fact that as soon as the OBGYN see galactoria, it's straight away CT. Why not MRI? I don't know. But anyway, they'll do some imaging of the brain for sure, rather than, analyze it for drugs or think of hypothyroidism, CKD, the things that we would keep in the differential possibility. So I think this has to be conveyed, because I don't know, because they straight away go for imaging, even if there is no hypertrophy, like you have shown pituitary hyperplasia or other. But I don't know how this can be sorted out. But a lot of times I've seen CT done, MRI done, everything done, but the thyroid is not looked into. So this is an important case from the learning perspective as far as physicians are also concerned.
So there's one question in the chat box. Somebody's asked, if prolactin is elevated in such cases, how and when to initiate cabergoline? So Sumaya, would you like to address that?
Yes, sir. So as I have shown in the mechanisms here, the hyperprolactinemia is due to hypothyroidism and not due to any other cause. So treating the hypothyroidism itself will resolve the hyperprolactinemia. There is no requirement of cabergoline here in this case.
In fact, when you have a patient with high prolactin, the first thing you see is thyroid, and then the other thing you take is a drug history. And most of the times, drug history is a culprit. Drugs are the culprit, and not the pituitary adenoma.
They're quite high. The prolactin can be quite high even with drugs.
Yeah, with antidepressants, it can go sky high. Even
you are tempted to do especially with the antidepressants, you're really tempted to do a CT to be absolutely sure. Sorry, an MRI. I'm sorry. MRI is definitely the imaging modality of choice, but I think it can, and then it lasts for long. It's not something that even once the drugs are discontinued, I think it can take up to a year almost to normalize. It can take that much time at least. In between, if the patient is given medication again, and these PPIs as well, which are very difficult to discontinue.
Levosulpiride, madam, started by GI gastroenterology, that also causes very high prolactin. So these are those cases where even with the correction of hypothyroidism, we may need to start at the end. Absolutely. If galactoria still persists. So I just was talking about the earlier case that she presented, madam. I think what you told was about the pericardial effusion. We have also seen one case of cardiac tamponade, which presented with hypothyroidism. And this case becomes rare because it is one of the causes of hypothyroidism with a tachycardia. So that's where the patient comes with that. And others also reported are AFib, SVT, PSVT, any infection with hypothyroidism, and sepsis are, of course, causes of hypothyroidism with tachycardia. And your first two cases, doctor, about the Van Wyck-Grumbach syndrome, essentially that we say Van Wyck-Grumbach when the presentation is of a precocious puberty, whether male or a female macroorchidism or that. So here, both your cases had come with either per abdominal mass, the first one, and the second one had come with a short stature. So the presenting complaint was still not the puberty, which was actually found out on inquiry for both the cases by you. So again, rare and atypical presentation. If you're looking at sonography or CT picture of this particular lady, is this particular girl that you presented, the demarcating feature is not a polycystic ovarian disease, but actually it is a multiloculated cyst in the ovary, which was there in your imaging. So that is one of the differentiating features where even before TSH, the mind can run that it could be an hypothyroidism. Thank you.
The mind has to know first, forgetting the exact words there. But
absolutely, ma'am.
You see what you know, and I agree with you. I think it was a very, very valid and important points. The only thing is, like, if you have significant anemia, we do say normocytic, normochromic anemia may be associated. Sometimes it is quite significant. I think even then, an anemia, you get tachycardia. So that could be another differential possibility, apart from, of course, what you're saying, Altamash.
Yeah. So I think we'll move on to the next two presentations, but these are basically just to show, I mean, that we still see very gross hypothyroidism, because in today's times, we with so much of thyroid testing going on, we all of us are wondering when not to treat with subclinical hypothyroidism, and when we don't have any symptoms at all and we have subclinical hypothyroidism detected, as compared to that in the extreme to extremely different scenario. We are seeing two patients whom Sumaya is going to present are present very late and very gross neglect. So even today we are seeing such patients. So we just wanted to show that. I mean, so Sumaya, next two cases.
Very nice. Very nice. Go ahead.
Yes. Coming to the last two cases. So case 5 is a 22-year-old lady who was admitted in medicine department with cardiac failure. And she was referred for short stature and incidentally detected hypothyroidism. And mother says that her height was similar to that of peers till around 10 years of age. Thereafter, there was a faltering of growth. They did not seek any medical help for the same. And she also had features of slowness in activities, lethargy, and also proximal myopathy. And birth history was non-contributory in her. Her milestones were appropriately attained for age, and she had average scholastic performance. And past history and family history were also non-contributory. Menstrual history, she attained menarche at 17 years of age. However, breast development started late at around 14 years, and there was poor progression. And there was no history of pubic or axillary hair growth. So general examination after stabilization revealed pallor, bilateral pitting pedal edema, pulse rate of 64 per minute, blood pressure 110 by 70 millimeters of mercury. And she had a gross height deficit of -8 SDS and a weight corresponding to -3.29 SDS. And we can appreciate the coarse facial features in her dry skin, facial puffiness, and her abdominal distension with umbilical hernia. She did not have any Turner stigmata. And her SMR was P1B3 with absence of axillary hair. She did not have any goiter as well. So systemic examination was unremarkable except for the features of cardiac failure, like in the form of bilateral crepitations, and she had ascites in the form of, so clinically she had shifting dullness and fluid thrill. And CNS examination, actually, higher mental functions were normal. MMSE was also done, which was 26 by 30. Motor system was suggestive of proximal myopathy, and deep tendon reflexes showed delayed relaxation. We could also elicit what is called the percussion myodyma in her. So this is her video, which shows a delayed relaxation of the ankle jerk. And this is a video showing percussion myodyma. So percussion myodyma is actually part of the hypothyroid myopathy. It's produced by applying stimulus to the contours of the bulk of the arm or thigh muscles. And that causes a visible and palpable non-tender ridge in the muscle, which subsides over a few seconds, and it does not spread anywhere along the muscle. So we can see that the mounting of the muscle happening and staying for like 1 or 2 seconds and returning. So the final clinical diagnosis here was juvenile onset hypothyroidism, long-standing, untreated, with short stature, hypothyroid myopathy, delayed puberty, anemia, and cardiac failure, which are possibly because of the anemia as well as long-standing hypothyroidism. Etiology most probably being autoimmune in her. And we can see that her TSH was more than 150 with low T4 and T3. Bone age, she had severe anemia, and bone age was 7 to 8 years, and ultrasound revealed a utopic thyroid gland with heterogeneous echo texture. Echo done at a later date was actually normal. Anti-TPO was high, 350 IU per ml, and a technetium scan also revealed a normal sized gland with a uniform uptake. So she was appropriately managed for the cardiac failure. She was given blood transfusion, after which the failure symptoms improved. And she was again, as the previous patient, started on 25 microgram of levothyroxine with up titration. So at follow-up at 6 months, we can see that her coarse facial features have resolved. Her height gain was around 3 centimeters, and there was resolution of proximal myopathy and clinical findings. So coming to the last case, which is actually again a 22-year-old lady. She was again admitted with similar complaints and referred to us for severe short stature and intellectual disability. She was actually a neglected child in the sense that she lost her parents very early in her life, and the antenatal natal history is not available. And but they report the grandmother, she was under the care of the grandmother. They report that there is gross delay in all the milestones since birth, and she has never attained menarche and never brought to medical attention till now. So this is the patient, and we can see that she has gross features of cretinism. She has pallor, and we can see there is maldevelopment of the naso-orbital region, which is very typical for cretinism. And she has macroglossia, and she also had features of malnutrition in the form of glossitis, angular cheilitis. She had a hoarse voice as well. She had abdominal distension, umbilical hernia, and her SMR was P1, B2 with absence of axillary hair. And we can appreciate the dry skin in her hands and feet. And anthropometry height SDS was corresponding to minus 11.8, 2 years, 6 months of height age, and weight SDS was minus 5.6, weight age of 3 years. And systemic examination, she could speak only monosyllables, could not comprehend, and she had bilateral convergent squint, severe spasticity, not able to walk, and she also had delayed relaxation of reflexes and percussion myodema. And this was the percussion myodema that we could elicit in this patient. So final clinical diagnosis, congenital hypothyroidism, long-standing, untreated, with cretinism, both neurological and myxedematous features, severe intellectual disability, short stature, hypothyroid myopathy, probable arrested puberty, chronic malnutrition, and anemia. So she had a TSH of more than 150 with very low T4 and T3, and ultrasound thyroid tissue was not visualized. So in her also, the management was almost same, but she was advised a high protein diet as well. And so the aspects to be highlighted were about two cases. One is hypothyroid myopathy, another is cardiac failure. So hypothyroid myopathy is a complication of uncontrolled hypothyroidism. It can be seen in all forms of hypothyroidism. Women are affected more than men. It can range from simple general myalgias to proximal myopathy to severe forms like Cocker-Debris-Simlane syndrome, which is seen in childhood, and Hoffman syndrome, which is seen in adults. So the pathophysiology mainly is T4 deficiency leads to reduced mitochondrial oxidative capacity and abnormal glycogenolysis. So there is selective atrophy of type 2 muscle fibers, which are dependent on the glycolysis. So these muscle fibers are actually replaced by slow twitching type 1 fibers. The second reason is deposition of glycosaminoglycans, and other reasons include poor contractility of the actin-myosin units, low myosin ATPase activity, and low ATP turnover, and decrease in muscle carnitine has also been implicated. Now, percussion myodema is actually one of the classical signs of hypothyroid myopathy and is entirely reversible by thyroid hormone replacement. And the mechanism here is delayed calcium reuptake by the sarcoplasmic reticulum following the contraction. So this is a normal contraction of skeletal muscle, which you can see that calcium ions are released from the sarcoplasmic reticulum. So when this reuptake is there, relaxation occurs. So when this does not happen, the relaxation is impaired. So the importance is that it's a rare and interesting clinical finding, and this sign, if elicited, can help differentiate hypothyroid myopathy from other types of myopathies. Now, very briefly on the mechanisms of cardiac failure in hypothyroidism. One is
we are going out of time.
Sir.
So let's stop here and
yes, sir.
Do some discussion.
Yes. Sir.
So the last case was actually very exciting. Like we hardly see those cases. They were what we was used to say 30, 40 years back. And in KGMC Medical College and All India Institute. And we used to see those patients. But these days they don't exist. Where do you find it?
Sir, she got admitted.
Yeah, so she was grossly neglected, as we hear from her story, that she's lost her parents and she was grossly neglected, and that's the reason why we're seeing such a presentation, so which we don't normally see nowadays. That's the reason why we thought that we'll
on the Middle Ages.
Yeah.
But that is the tragic. The point is this: where is the thyroid hormone coming from? I mean, after all these years, where? I mean, it should be like, do we actually? Well, it's going to cause mortality, right? Isn't it? Do we miss, or we don't pick up so many? Maybe what Dr. Batra is saying, because they die. I don't know. I'm just wondering. These are the ones that have still some thyroid reserve.
No, I think this is actually because if you take the history of this patient, she was the patient was an orphan and brought up by the grandmother who didn't know anything, who was probably old, and probably never saw a doctor in her life.
But I think the take-home message here is all short stature. All short stature, that goes without any exception. All short stature must be investigated for hypothyroidism.
And look at the damage that the deficiency of a few microgram of thyroxine can do.
That makes me feel so bad that we're still, from the Indian Thyroid Society, we're not able to do anything regarding the neonatal screening. I don't think we're going to make any headway there in our country. For how long, I have no idea.
So, Sumaya, one last question. This is congenital hypothyroidism. So what are the causes?
Sir, it could be endemic, or it could be genetic or sporadic. So endemic because of the maternal iodine deficiency, it could happen, or it could be because of genetic causes like a thyroid agenesis or a dysgenesis or a dyshormonogenesis, which could be sporadic as well, sir.
Any more questions for the faculty?
I think we are running a little bit short of time. We have to go ahead with the quiz. Please.
Sure. Then let's stop here and let Dr. Pramila take over.
Thank you.
So we go ahead with the quiz now, and I invite Dr. Altamas Sheikh. And can we have his CV, please?
We need the rules to be, the rules of the quiz also.
Yeah, rules also I'll just tell. So the quiz will be conducted today by Dr. Altamas Sheikh. He's a senior consultant endocrinologist and metabolic super specialist at Mumbai. And he has specialization in diabetes, thyroid, PCOS, and all the endocrine disorders. And I'll just read the rules of the quiz, and then we'll have 2 dummy questions, and then we go ahead with the quiz. So we can have the rules of the quiz, please, displayed. So please have a Zoom app on your mobile device or laptop. It's better to do it from the laptop because that will be easier for you. The quiz will run for 10 minutes, and there'll be first 2 dummy questions followed by the actual quiz. And Dr. Altamas will display the case or the description by the PowerPoint file. So you just see there, and then you have the polls option to participate in the quiz. All 12 questions will be available when the poll is launched, and the answer for all the questions is to be submitted at once at the end of 10 minutes. And if you want to read the case or the description, you can close the polls using the X button and again use the polls option to answer the respective question. So can we have the next question, dummy, please? Yeah. So we'll first have the 2 dummy questions. And those dummy questions have no controversy, no debates. So we'll go to the dummy. So in which city is Taj Mahal? That's Chennai, Mumbai, Agra, or Bangalore. And how many oceans are there? 8, 5, 6, or 7? Smita, can we start with the quiz? Dr. Altamash can share his screen.
Sure. Thank you so much. Good evening, everyone. It's been a pleasure to be here. I think Madam Sarita is really to be applauded for this particular quiz session. She actually planned this 6 months ahead, and she actually called me somewhere in April, May, that Altamash, would you be doing a quiz of this kind for us? So what I'm going to share right now, thank you, Madam, for inviting. So what I'm going to share is the first question that we see on the screen. And visible?
Yes, sir, it's visible.
Yeah, visible. Yeah.
Okay. So incidence of thyroid carcinoma with insulin resistance is same as general population, is low compared to general population, is high approximately maybe 10 to 20%, or is very high more than 50%. Do we give them time to answer?
Yes, sir, 10 seconds.
10 seconds, 10 seconds.
Second question, can I?
Yes, sir.
Please, please. Yeah.
A 25 years old male with high TSH comes with this kind of a picture. What would you label him as? Pseudoacromegaly, a giant, isolated prognathism, or a skeletal deformity? Question 3. All except are the factors influencing serum TSH in hypothyroidism: race, age, obesity, euthermia. All except. Question 4. False about thyroid and COVID-19. 1. Uncontrolled thyrotoxicosis may be associated with severe complication. Point 2. Symptoms of infection from COVID are indistinguishable from those of antithyroid drug-induced neutropenia. 3. You would continue the same dose of antithyroid drugs. And 4. You would send neutrophil measurement urgently. What is false in this? Next. Product of this plant interferes in thyroid disorders in measurement. What is the product of this plant? Is it calcium? Does iron come from these? Does coffee come from these? Or does soya come from these? Next. False about food in the treatment of hypothyroidism. Thyroxine should not be given with soya, iron, or calcium preparations. Cruciferous vegetables and soybean-related foods interfere with thyroid hormone production or use. Unless there is a coexisting iodine deficiency, these foods are generally of no clinical significance. Or option 4, goitrogens are activated by heating and cooking. What is false about food in treatment of hypothyroid? Next, advantages of liquid thyroxine formulation include all except ability to deliver more precisely the individualized dose for infants. 2, unaltered absorption when it is given with milk. 3, possible increase patient satisfaction over tablets while comparing with the liquid thyroxine. Or number 4, liquids and tablets have non-equivalent weight-based dosing. all except. Statement that is false about thyroid cancers. FTC usually presents as a unique tumor and shows increased potential for hemat spread, mets to lungs and bones initially. 2. In contrast to PTC, cervical lymph node metastases are rare in FTC. 3. The two most common histological types of cancers are PTC and FTC, comprising the DTCs. Or number 4, in children and adolescents, DTC is responsible for more than 95% of thyroid cancers, with MTC accounting for 90% of cases. Next, which cancer is seen in this thyroid tissue? It's a histological piece. 1. Papillary thyroid carcinoma. 2. Medullary thyroid carcinoma. 3. Follicular thyroid carcinoma. Or 4. None. Not a potential symptom or sign of thyroid cancer is persistent cough, raw throat not relieved by routine treatment, difficulty in swallowing without goiter is seen in neck, or 4, hoarseness or voice changes that does go away with routine treatment. I think we are done with 10 questions.
So thanks, Dr. Altamash, for the quiz. And we will be having the winners in the end. So you have to stay till the end. So you'll be announcing the winners. So after Dr. Vaishali Deshmukh's session. So now I welcome Dr. Vaishali Deshmukh, and can we have her CV, please?
Thank you.
She'll be taking us through the next case presentation. So can we please have the CV of Dr. Vaishali, please? So our next case moderator is Dr. Vaishali. She is Asmita. We can have the CV, please, Asmita. So Dr. Vaishali is a senior consultant endocrinologist from Pune, and she'll be moderating the next case discussion. So it's a very interesting case, and it's not very common. So just to introduce Dr. Vaishali, she is a consultant and head of endocrinology at Dinanath Mangeshkar and Deshmukh Clinic, Pune. She is an assistant professor of endocrinology at Sassoon General Hospital and BJMC, Pune. And she has 26 publications to her credit. And she is very much interested, we all know, in mind-body medicine and neurobehavioral endocrinology. And she has been a gold medalist, and she got the Proficient Women Award and the various other awards to her credit as well. So I welcome Dr. Vaishali to start the next case, please.
Thank you, Dr. Pramila. Let me start first with congratulating Sarita Madam and Indian Thyroid Society. I think they're doing a wonderful job of educating people on thyroid, and especially endocrinologists who are budding. I remember in my student days, it was learned only in the respective OPDs with our individual teachers, but the students are fortunate to have you, ma'am, today. So I think these clinics are definitely going to be of help. So we have an interesting case coming from Dr. Varsha Kashru. She is from a second year DNB student from Indraprasth Apollo, Delhi, and she'll be presenting 2 cases of pituitary metastasis. Go ahead, Dr. Varsha.
Thank you for the introduction, ma'am. I will share my screen now. Are my slides visible, ma'am?
Yes, they are. Please go ahead.
Okay. So a very good evening to everyone. Today, I'm going to present an atypical case of follicular carcinoma thyroid. Although I wasn't directly involved with this case, I got to see only the initial few glimpses of this patient because she was mainly evaluated in the AIIMS Delhi. But since this case was quite unique and infrequent that we don't see it in the daily practice, so we decided to present this in this thyroid clinic. So starting with the case. So coming to the history first, a 26 years old female homemaker presented with history of swelling over left side of the neck since 4 years. There was history of fever, headache with sudden onset loss of consciousness 1 month back before her presentation to the Apollo hospital. There was history of sudden onset headache and loss of vision in the left eye at the time of presentation to the Apollo hospital. So history of present illness, patient was apparently well when she noticed a small nodule over left side of neck 4 years back, gradually increasing in size. There was no history of dyspnea, dysphagia, hoarseness of voice. There was no family history of malignancy or any radiation exposure. And there was no history of radiation exposure in her childhood as well. So she was investigated at that time. And investigations, these were the investigations which she had done 4 years back. So these were done by some local practitioner. So ultrasound thyroid done at that time was, it showed 3.2 by 3.2 centimeter hypoechoic mass, well-defined margins on the left side with no calcification. Isthmus and right lobe of the thyroid were normal. FNAC thyroid showed follicular cells suggestive of adenomatous nodule. She was prescribed tablet levothyroxine 25 microgram per day. So we couldn't elicit what was the indication for starting this. She was irregular with the medication and stopped these after 1 month of initiation. And the follow-up visit, she was advised thyroid scan, which revealed a cold nodule left side. She was then advised for surgery, which she refused. So this was her technetium 99 thyroid scan. What we can see here is the thyroid uptake on the right side. It is normal, and it is relatively decreased on the upper 2/3 of the thyroid, and it is absent in the 1/3 of the left thyroid with background normal uptake of the salivary glands. So this is how they made an impression of the cold nodule present on the left side. So these were the absolute values. So technetium uptake on the left lobe was 0.2%, and the reference range for this was 0.4 to 4% at the end of 20 minutes. So there was no follow-up after this. 1 year prior to the presentation, that means 1 year prior to the presentation at Apollo Hospital, there was a progressive increase in swelling. She again sought medical attention and was found to have TSH 9.1 and total T4 of 7.7 microgram per dl. That means a picture was of that of subclinical hypothyroidism. She was started on thyroxine 100 microgram daily, which she was taking again irregularly, didn't undergo surgery for the nodule. Then 1 month prior to the presentation at Apollo, there was history of fever. It was high-grade fever, continuous, lasted a month. She was given antibiotics for possible pelvic inflammatory disease. Fever got resolved. Fever recurred after 10 days. Then it was associated with headache, which was holocranial in nature, and there was loss of appetite. She had 1 episode of loss of consciousness. So again, she went to a local hospital. NCCT brain was done, which was normal. Her lumbar puncture was done, which showed a total count of 150 cells, and they were predominantly lymphocytic. So they started her on ATT, anti-tubercular drugs, along with steroids. She took ATT for 1 month. Following that, there was a sudden onset of headache with loss of left eye. So this was after 1 month of starting ATT. She had a sudden onset headache with loss of vision. So this was 7 days back from the time of presentation to the Apollo. Again, she went to the local hospital where her MRI brain was done. So this was the MRI brain, which was done outside Apollo hospital. And here we could see 35 by 35 by 30 mm ill-defined expansile extraxial mass involving body and left greater wing of the sphenoid bone. There was breach of superior and left lateral wall of sphenoid sinus with intracranial extradural soft tissue component causing mass effect on the pre-chiasmatic part of the bilateral optic nerves. So it was also reaching up to left orbital apex, and it was encasing carotid segment of the left internal carotid artery and extension into the left ethmoid air cells and reaching up to left orbital apex. There was no definitive intraorbital extension seen. So findings, they were suggestive of neoplastic etiology, and as reported by the radiologist outside, they had given a possibility of chordoma due to the extensive nature and expensile nature of the tumor. And since there was this sphenoid sinus invasion, so they had likely put a possibility of more invasive tumor, which was, according to them, was chordoma. So coming to her menstrual history, she was amenorrheic by the time she presented to us, and amenorrhea was for 2 months from the time of presentation, and her urine pregnancy test was negative. So there was no significant family history. Coming to the physical examination, so her general examination consisting of a BMI, vitals being pulse rate was 86 per minute and it was regular in rhythm. BP was also normal, and systemic examination didn't reveal any significant finding. So when we did her visual examination, so visual acuity in the left eye was, she could do finger count at 2 feet distance, whereas visual acuity in the right eye was 6/9 using Snellen's chart. And her peripheral field was, there was severe field defect in the temporal field as compared to the nasal field on the left eye, and whereas peripheral field on the right eye was normal. Fundus in the both eyes were normal. So thyroid examination, she was having a grade 3 goiter, multiple nodules were felt. So largest nodule was well-defined, firm to hard and non-tender swelling, 5/5 centimeter present on the interior side of neck, moving with deglutition. Skin over the swelling was normal. There were no dilated veins or pulsation, and Pemberton sign was negative, and there was no bruit. Breast stage, it was stage 5 as per Tanner staging, and she had expressive galactoria present bilaterally. Although this was not her presenting complaint, we could elicit only after expression that she had this galactoria. So coming to the investigations, so these investigations were again done outside the Apollo Hospital, and most of the investigations, including her CBC, RFT and LFT, were within the normal reference range. Her thyroid profile again was in the subclinical hypothyroidism range with TSH of 8 and FT4 of 1.1 nanogram per ml, as we already know that she was quite irregular with the medications. So this was her perimetry, and we can see the field of vision on the right eye is completely normal, whereas there is total loss of field of vision on the left eye. So diagnosis was invasive pituitary macroadenoma, compressing optic chiasma with loss of vision left eye, subclinical hypothyroidism, and multinodular goiter. So what I wanted to highlight at this point of time is that she had presented to the neurosurgeon at the Apollo Hospital for the direct surgery of this tumor as recommended by her local practitioner. So following this, she had her surgery. So transnasal, transsphenoidal, and microsurgical decompression of sphenoidal cellular supracellular tumor with repair of cellular floor with fat and fascia was done. Intraoperative findings were there was thinned out sphenoid wall, tumor filling sphenoid sinus extended into cellar, grayish firm fibrous highly vascular tumor was present. Frozen section was suggestive of pituitary adenoma. So post-operative course, she was shifted to neuro ICU. She was given IV fluids, analgesics, and antibiotics, and prophylactic antiepileptics. Post-operatively, vision in the left eye improved completely. So the neurosurgeons, they had advised for a repeat CT head. So there was invasive mass lesion in sphenoid sinus with cellular and left paracellular extension eroding into basisphenoid, post-ethmoid, and maxillary sinus. That means they couldn't totally remove the tumor, but however, they were quite satisfied with the clinical improvement. That patient had quite her left vision in the left eye was improved completely. So she was discharged on oral antibiotics and steroids. So they tapered in the dose of 4 milligram once daily for 5 days, followed by 2 milligram for 5 days, and then they stopped this. And thyroxine, the dose of thyroxine which was given at the time of discharge was 125 microgram, and valproate sodium 500 milligram twice daily was prescribed for 1 month. Then we had her surgical specimen histopathology. So this was her surgical specimen histopathology. So here we can see in the lower part of magnification that this is basically the bone, which is the sphenoid bone, and this is being invaded by the tumor. So on the higher part of magnification, we can see that there is presence of this thyroid follicles. As we can see, these are the cuboidal cells, although we can't totally demarcate each of the cells, but we can see there is a presence of follicles, and in some of the follicles there is a presence of goiter. So this was the atypical thing which we had found in the, which pathologists had found on the histopathological specimen. So further on the higher magnification, this is what we can see is there is the presence of the thyroid follicles in the clusters, and they were in significant amount. So this was again an atypical finding, that where from a pituitary specimen we are getting these thyroid follicles. So further the immunostaining was done. So this was her Ki67 index. So it was MIBI index and Ki67 index, they were quite low. And this was the immunostaining done for the thyroglobulin. As we can see, the colloid in the thyroid follicle, there is immunoreactivity for the thyroglobulin. So again, confirming that the source was definitely from the thyroid. So this was for the synaptophysin. This immunostaining was done to rule out whether any involvement of the parathyroid thing is there or not. And this was the immunostaining done for the pancytokeratin, which was again positive. And this was the immunostaining which was done for TTF. So now at the end of this histopathological specimen examination, we had the possibility that this is possibly a metastasis from a primary thyroid carcinoma. Now the diagnosis changed to primary thyroid carcinoma with metastasis in the sellar and suprasellar region. So here we got the glimpse of this patient, and now we had advice for anterior pituitary trophic hormones and FNAC thyroid, total thyroidectomy based on the results of the FNAC. So this was our plan of the treatment for the patient when she had presented to us. Biopsy of the tissue, whole body radioactive iodine scan, and 131 iodine therapy, and radiotherapy of the residual sellar and suprasellar mass. But in view of the financial constraints, we had to refer the patient to AIIMS Delhi. So following this, I will be presenting the course of the patient which she had undergone at AIIMS Delhi. So there they had performed the investigations consisting of anterior pituitary trophic hormones. Here we could find that there is cortisol on the lower side, that is secondary adrenocortical insufficiency was present. So she was started on steroids for the same. T4 was in the normal range and TSH was 1.42, again within the reference range. So she was admitted after 1 month of pituitary surgery. The slides and blocks from our hospital were reviewed, and she also underwent FNAC thyroid, which showed follicular lesion, and features were suggestive of ATP of undetermined significance, that is Bethesda category 3. As already told, she was started on steroid replacement for her low cortisol level. So ultrasound thyroid, again, it was done, and there was hypoechoic, predominantly hypoechoic lesion, 6.9 by 3.4 centimeter, with a few cystic areas seen in the left lobe of the thyroid and isthmus. And now it has been labeled to have query a malignant etiology, which 4 years back it showed just an adenomatous, or we can say colloid goiter etiology. And the right lobe appears atrophic. FNAC thyroid, again, it, as already said, it showed the ATP of unknown significance, the Bethesda grade 3. So histopathology block review from Apollo Hospital, again, they confirmed with the same thing, that the cells from the pituitary sella or the surgical specimen, they are immunopositive for thyroid transcription factor 1 and thyroglobulin. And the specimen was compatible with metastatic thyroid carcinoma, and no normal pituitary tissue was examined in the surgical specimen which was examined. So then this patient underwent total thyroidectomy. There was no post-operative hypocalcemia or recurrent laryngeal nerve palsy. So histopathology from the thyroidectomy specimen, it showed grossly, a specimen measured approximately 45 grams. The externally on the gross examination, capsule was intact. The serial slicing showed solid gray white tumor nodule in the left lobe, which was measuring 6.5 by 4.6 by 3.4 centimeter. This was again on the gross examination, and it lies less than 1 mm from the nearest capsule, and there was no capsular breach or extra thyroidal extension seen grossly. So multiple sections from the tumor in left lobe showed an encapsulated tumor with cells arranged in trabeculate sheets and focally microfollicles. So capsular along with focal vascular invasion, a single vessel was involved. So this was seen microscopically. There was no nuclear enlargement with focal growth along with areas showing metaplasia. So overall features, they were quite compatible with follicular carcinoma, and the rest of the thyroid showed adenomatous change. So following this, she was given recombinant TSH instead of thyroxine withdrawal regimen because as they had thought that there was possibility of inadequate TSH response because patient had already undergone a pituitary surgery. So in order to avoid the symptoms of hypothyroidism and the secondary hypocortisolism, which can be flared up due to the presence of the secondary thyroid deficiency, so they put the patient on, they had given the patient 2 injections of recombinant TSH or thyrogen, 0.9 milligram intramuscularly on day 7th and 8th following the thyroidectomy surgery. Following this, whole body radioactive iodine 131 scan was done and ablation was done. So patient had received 100 microcuries of the same on the 3rd day following recombinant TSH administration. So these were the labs after 2 days of the therapy. So TSH, this was following recombinant TSH was given on the 1st day, and this was the lab after 5th day. So this might have probably decreased due to the half-life of TSH, recombinant TSH being approximately 16 hours, and thyroglobulin levels were pretty high. They were 13-14 nanogram per day, and anti-thyroglobulin antibodies were on the higher side of the reference range. So this can be attributed again to the fact that whenever there is an insult to the thyroid, either in the form of surgery or in the form of radioactive iodine ablation, so anti-thyroid thyroglobulin antibodies can be on the higher side. So then this patient was subjected to radiotherapy after PET CT and SPECT CT was done. So which showed uptake in the remnant bed and faint uptake in the lytic lesion in the sphenoid and ethmoid bone involving sella. So radiotherapy to the osteolytic lesion in the sphenoid bone involving sella was planned. Now, final diagnosis was follicular carcinoma of thyroid with pituitary mets from the follicular carcinoma, primary hypothyroidism, and secondary adrenocortical insufficiency. So treatment as already discussed. So the
I think we can, if we can go on with the discussion, it is better because we have less time now. So you can just cut it short and you can just say major things about it, and then we'll have some time for discussion as well, because discussion is more important.
So pituitary mets, it was first reported by Benjamin in 1857 from malignant melanoma. So it mainly affects elderly patient in the 6th or 7th decade of life. And usually they come from the breast if the patient is female, and mainly from the lung if the patient is a male, as is said in the literature. However, there is no clear gender predominance. So pituitary metastasis is found in 1% of cellular and paracellular tumors. Only 2% of the pituitary metastasis is reported from thyroid. The route of spread of this metastatic deposit to the sella, they usually come from hematogenous spread, as posterior pituitary, it gets a direct blood supply as compared to the anterior pituitary. It can be through portal vessels, local spread through erosion of the skull base, or it can be the meningeal spread through suprasellar cistern. So this was the study. This was basically the study of John Comenos, who did a review of and reviewed many series on this pituitary metastasis. So what he had found was that from the surgical specimen, the incidence of the pituitary metastasis was approximately 1%. And when the series for autopsy from all systemic cancer were reviewed, the incidence was approximately 5.1%. So as already said, that breast is the most common site for the pituitary metastasis, and the incidence is approximately 39.7%, followed by lung 23.7%, and in 3.1% cases, the incidence remains unknown. The pituitary metastasis, the most common clinical presentation as reported in many of the series is diabetes insipidus, as already said, due to the involvement of the posterior pituitary because of the lack of the direct anterior blood supply of the arterial blood supply of the anterior lobe. So other features are cranial nerve deficit, or usually sometimes the patient can also present with the symptoms of the malignancy like malaise, body aches, generalized body weakness, and many times patient can be asymptomatic. Other things can be headache, post-ocular pain, fatigue, hyperprolactinemia, and pituitary apoplexy reported in lesser percentages. So differential diagnosis is first, as was in our case, pituitary macroadenoma, but they usually have optic chiasma involvement. They don't have DI at the initial presentation, and there is no other cranial nerve involvement. So this is how we can differentiate. However, there is no definite differentiation features, but the thing is that the rate of progression of the pituitary metastasis is quite, we can say, on the aggressive side as compared to the pituitary adenoma. So treatment is mainly palliative. It depends on the symptoms and extent of the systemic disease. Lesions are firm, diffuse, invasive, vascular, and hemorrhagic. Hence, total resection of the entire tumor is unlikely. So we can go with the local radiation and chemotherapy as the initial course of treatment, plus pituitary hormone substitution. The transsphenoidal approach, completeness of resection and aggressive treatment are associated with symptom relief, but they don't affect the survival rate. Prognosis is not on a favorable side. Mean survival length in clinical series has been reported to about 6 to 7 months, and patients with a single pituitary mets, they have a better outcome. But overall, the prognosis of the pituitary mets is poor due to the aggressive nature of the primary tumor and not due to the location of the tumor. So to summarize, I can say that suspect pituitary metastasis in older patients with history of malignancy and with DI on the initial presentation. Pituitary metastasis from thyroid cancer is rare. Anterior pituitary deficiency, hyperprolactinemia, diabetes insipidus is less common in pituitary metastasis from thyroid carcinoma as compared to other sites. So mets from thyroid cancer, pituitary mets from thyroid cancer, they show tendency to progress, becoming huge lesions with compressive features. And pituitary mets from thyroid cancer tend to be rapidly progressive paracellular lesions that destroy pituitary and present more often as mass effects.
Yeah, so thank you, Dr. Varsha. I think that was an extensive, elaborate description of the case. I think it has been worked up very well and well managed. And in fact, the whole team has been very proactive in getting her treated rightly. Now, I just wanted to highlight few important points here, that in such cases, because I work in a tertiary cancer center, in such cases, to avoid the delay and time lag that has occurred in this patient, we usually have a tumor board for this, where every specialty comes together and discusses the case. So there is no time lag between moving from endocrine to neurosurgeon or to radionuclear medicine. I think that is one thing which we should avoid, especially when we are talking of aggressive malignancies and metastatic malignancies, because that, for example, you said that this patient was advised surgery, but did not opt for surgery because probably she needed a depth investigation on malignant possibility there. Because what would you have done as an endocrinologist? Suppose this patient came to you with a Bethesda 3 category nodule, and you would leave the patient, or what would you advise? Next to diagnose?
Next to diagnose, we can, nowadays it has been suggested that we can go for molecular studies, ma'am.
Molecular studies?
So we can subject the specimen to this BRAF and RAS staining, and based on the whatever results we are getting, we can subject the patient to thyroidectomy if there is the staining positivity for that high risk molecular markers.
Have you heard of liquid biopsy? Plasma cell liquid biopsy. Dr. Sujay Ghosh has presented his paper, and it's been a unique study in India. What is free DNA?
Sorry, ma'am?
Plasma cell DNA analysis, liquid biopsy.
Liquid biopsy.
Okay, so I'll just mention over here for your benefit that Bethesda category 3 and 4 can be subjected to a biopsy of the plasma cell DNA. The plasma cells are analyzed. The plasma is analyzed for presence of free DNA. If the DNA count is more than 68%, it favors a possibility of malignant nodule versus a benign nodule. So it means that the tumor somewhere is producing DNA, which is a mutant DNA. And that's the easiest way. And I think Dr. Sujay Ghosh and team is working very well on this. You can go through the paper in the IGIM on this. And second thing that you can go through is genetic panel that is now easily available at the genetic centers. So which mutations would you look for mainly in such a patient with aggressive metastasis of a differentiated?
For follicular thyroid carcinoma, the mutations we are having, ma'am, is the RAS mutation. It is the PPR gamma and the PAX8 recombination. Then we are having HRAS, KRAS mutations, ma'am.
Okay, and do you think of referrals to oncology, medical oncology in this? Because I don't see any chemotherapy offered to this patient. When do you offer chemotherapy into such category of patient?
Chemotherapy, ma'am, whenever patient is falling in the category of ATA high risk, then we can offer the patient, or our patient is falling into the on follow-up visit, patient is falling into the category of the high risk of recurrence.
So have you done the risk stratification? How do you do that?
Risk stratification, ma'am, it is done on the basis of the thyroglobulin. It is done on the basis of the what is the stimulated thyroglobulin and what is the
TNM classification?
TNM classification, it is based on tumor, nodes, and metastasis, ma'am.
So what does it do?
They basically, it can be done either clinically before the patient has undergone the surgery, or it can be done post surgery, which is called the pathological specimen staging.
So TNM is the risk stratification strategy. So when you do TNM, you are stratifying the patient. So where do you put this patient as TNM?
On the TNM, it is falling, ma'am. It is T1 and N0 and M1.
T1, you want to say when you have follicular CA in the, it's not invading the strap muscle. It's more than 5 centimeter nodule. You want to put it as T1 or T3? You'll go and read it again and you'll try to classify this patient based on TNM. Because why is it important to classify and stratify this patient? Anyone can answer this from the students. Okay, it is important to classify this TNM because any M1 is going to decrease survival to nearly 30%. So 70% is the survival up to M0. So anyone above M1, that is the stage 3 and 4 disease, their chances of long-term 5-year survival comes down by half in these patients. So it is important to stratify this patient. And when you're putting them as M1, then the follow-up is based on all the 4 departments. It's not only endocrine alone. So this patient will need a follow-up with a radionuclear person. He'll need a follow-up with a radiation oncologist, with a chemotherapist. And in fact, I was a part of one of the studies for such a type of patient cancer. Lenvatinib was the molecule. Lenvatinib was the chemotherapeutic agent. And this was offered to such patients who are refractory to radioiodine. Now, how do you identify whether this patient is radioiodine refractory? That's the second question.
Radioiodine refractory, ma'am, we can repeat the thyroglobulin. We can have the 4 to 6. Initially, we do it after 6 weeks after surgical thyroidectomy, total thyroidectomy. Then we can have it after 6 monthly thyroglobulin, repeat thyroglobulin. And along with that, we have to do anti-TG antibodies.
But when do you say that this patient is not responding to radioiodine, or you'll just follow up this patient with TG? You have any criteria defined for labeling this patient as radioiodine refractory?
Radioiodine refractory, ma'am, whenever this thyroglobulin level on the in the high risk patient are basically our response we are seeing it on the basis of whether this thyroglobulin is stimulated or whether it is unstimulated. So unstimulated thyroglobulin, it should be less than 0.1 to 0.2, and the stimulated thyroglobulin, it should be less than 1 nanogram per ml.
I think I'll just mention that the refractoriness of radioiodine is dependent on 3 criteria. One is when the patient requires more than 600 millicurie of dose cumulatively. So if this patient has been following up, say, for 5 years, 10 years, and has received more than 600 dose, you cannot offer much more beyond that. Why so?
Because of the stunning.
Stunning, and what else?
Because of the risk of the malignancy.
Other malignancies risk will increase. And second, refractoriness is defined by lack of intake of iodine by at least one of the metastatic deposit. So this is the second criteria. So if one of the secondaries doesn't take up iodine, it's labeled as refractory. And third important point is that the thyroglobulin, as you said, will keep on increasing. And not only the thyroglobulin, but also the thyroglobulin antibody. So, yeah. So both, if they are rising, in spite of you offering radioiodine, you label them as refractory. And then you think of moving to chemotherapy. So I think it's not one man's job. It's a tumor board that is required to take the decision on follow-up of such a patient. I think that's the major take home today. And second important thing in any thyroid malignancy, I think we don't have much time, so I'll just tell you the key gist of any malignancy for that matter. There are 4 things. One is locoregional debulking or treatment. Second is identifying where the metastasis is. So here we have 3 metastatic sites. If you see the whole picture in clear, there is a CNS metastasis to pituitary, there is a bone metastasis to the sphenoid, and there is a lung nodule in one of the PET CTs. So there are 3 sites of metastasis. So this patient becomes an aggressive metastatic patient. And third thing you identify is what is the risk of this patient. So with the TNM. And fourth thing, that TNM has to be done dynamically. Every follow-up visit will be a dynamic TNM assessment. And once you have done that, every time the tumor board meets, and then takes a decision as to what would be the next step. And chemotherapy has a lot of side effects. So you don't offer it to all. You offer it only to symptomatic patients. So this is what you need to remember. And the purpose in cancer therapy is improving survival. It's not only just following them up. So are we improving survival is what we need to see when we are monitoring such patients. So I think this whole thing summarizes your approach, and we need to look more into the genetic aspects at the right time. As endocrinologists, we can actually convince our patients to go to the surgery at the right time rather than have this kind of a metastatic spread. So I think the first endocrinologist who has seen the patient has the job of convincing the patient to go in for a surgery. Of course, patient factors do exist, but I think the case was excellently worked up and a very unique case, and a lot of things to learn from this case. Of course, we should not forget our pan-hypopituitarism management and bone health management and all those allied issues, because we are not oncologists, we are endocrinologists. So we have to deal with our profession. Thank you so much. Thanks a lot.
One thing I want to add is
please.
This patient is now 5 years post-surgery and post-radiation. She's still alive. That's something that's important.
So the survival for 10 years is around 35%. So I'm sure this patient
35% in what?
In such patients where they have been appropriately treated. So 25 to 30% is the survival in appropriately treated and suppressed patients.
In patients with pituitary metastases.
Yes, of course. And these who are receiving radioiodine therapy. So 10-year survival data shows that 28 to 30% of patients can survive if the MIB index has been low, if they have not been grossly aggressive in nature. So anyways, but I think we'll like to know the follow-up of this patient 5 years down the line. Definitely.
Yeah. Maybe next thyroid clinics after 5 years we'll get that answer. Okay. Only thing to add is, like, this is a very good case because, but the thing was that it was primarily a thyroid cancer which you diagnosed, and then we went ahead. We had a similar case we had presented in the thyroid clinic a few months back, where the patient had actually presented as a pituitary adenoma, and she had a high prolactin, and she also had galactoria actually. So she presented with galactoria with the prolactin which was in dilution around 215 nanograms per mil. And she presented with ptosis, and she had a large pituitary mass, and it was actually thought of as a pituitary adenoma. We did see her thyroid, and the thyroid had one nodule which was, FNAC was done, and it did show Hashimoto's, and none of the ultrasound evidence showed any evidence of cancer or any TIRADS, like all nodules were TIRADS 2. And then when the patient was thought of as, initially we thought it could be a prolactinoma. We gave a trial of cabergoline also for a month or so, 2-3 months we gave. The size didn't change, and because the tumor size and the prolactin level were not matching, so we went ahead with the pituitary surgery. And when the pituitary surgery was done, the biopsy showed off that it is a thyroid follicular CA. And then we went ahead and did the thyroid surgery. So because biopsy showed it, so there was no question of a doubt. And then thyroid surgery was done, and then it was shown as a follicular thyroid cancer. So the learning experience for us was, like, because we did not suspect that this was a metastasis from the thyroid in the first instance, because the presentation was very atypical. Like, this was more of a typical, you had something which was there and you were suspecting. There we weren't even suspecting, and we got a surprise when the biopsy came in the evening. And then obviously we went ahead with the usual management of the patient. So that was one of the learning experiences. So sometimes we do get a different scenario which may not be very straightforward, and we can have a lot of surprises. So now we have made it a point that any patient who comes like this, where we have some little bit of a atypical thing, we always do investigate other things. So this is how we learn over a period of time. So that was one case which was similar to it, but the presentation was entirely different, like a prolactinoma with galactoria. And also one thing which nicely she has pointed out, Dr. Varsha, that we have to make everybody understand that when a patient has secondary hypothyroidism, then they cannot have a stoppage of the levothyroxine for the TSH to rise. So thyrogen has to be given, because recombinant TSH has to be given before radioiodine. Because many a times it was very difficult for us to even convince, because she was referred from somewhere, so she had some insurance. So we had a lot of problems in convincing the insurance people that why recombinant TSH is required for her. Because everybody was asking, we can stop the levothyroxine, and why can't we do that way the radioiodine scans? Why we need to give recombinant? So the message also is that recombinant TSH will be required, because she is a secondary hypothyroid. The TSH rise will not happen in her. So that was another point which is take home from this, because many a times as endocrinologists we know, but the physicians may be not very much aware of this.
One more point to add to what you said is that I've seen that before radioiodine, most of the surgeons would do a scan, and they would give a iodinated contrast. This is commonly missed by even the nuclear medicine people and even the endocrinologists, that they come with a iodinated CT done a month before, and they take iodine, and then the uptakes are very poor, or they do not respond. So I think one thing which all of us need to remember is that you should always ask a history of whether there any CT or contrast has been given to such patients before iodine, at least a month prior. So you should not be having that kind of a scenario.
Absolutely, because these things are very important, because it can change our whole result. And we may think it's not responding, or patient has not picked up in the scan. So a lot of things we need to see in the history, and whatever the other things have been done before, as Dr. Vaishali rightly pointed out. Yeah. Ma'am, your comments, and then we go on.
Excellent presentation, Dr. Varsha, and a very nice case presentation. Thank you, ma'am.
Excellent. It was a well done case, and yes, ma'am, please.
I think he's waiting, no? I think we have that other case also to discuss, the one that was presented by Dr.
So yes. Is he there in the thing?
He's there.
He's there. Please, can you tell the follow-up of that case, and just give a gist of the previous, so that the people who didn't join last time will get an idea what exactly we are discussing. Your sound is not coming. We can't hear you. Can you just see if your earphones are not connected? Yeah, because we can't hear you. We still can't hear you. Maybe your microphone has to be, like, you have to see the volume. If your volume is less, we can't hear you. Now we can hear.
Yes, ma'am. Thank you, ma'am. Can I share my screen, ma'am?
Yes, please, please, please. And just be brief about the previous history, so that people get an idea what we are discussing actually.
Sure, ma'am. Sure, ma'am. Yes, ma'am. Ma'am, this is a case of cellular mass with a markedly elevated TSH. Is it thyrotrope hypoplasia, or is it a pituitary adenoma? Was the discussion last time we had, ma'am. He is a 62-year-old gentleman who was referred in view of a cellular lesion and with symptoms like weakness, easy fatigability, dry skin, constipation, and grade 1 goiter without headache, visual fields disturbances, or any signs of raised ICT. There were no other excess deficiency or deficiency of any other anterior pituitary hormones or any other neurological deficit noted, ma'am. So he got incidentally detected. He actually presented with the complaints of neck pain, for which CT was advised, and it revealed a lesion. Cellular lesion. It is a clear dome-shaped elevation. I'll show the pictures, ma'am. So these are the MRI images of the patient. It's a T1 coronal sagittal image, which was showing a clear 1.1 into 1.6 into 1.4 centimeter dome-shaped elevation, which is mostly homogeneous, but a slightly heterogeneous component seen in hyperintense component seen in the T1 coronal section. And this is a posterior pituitary bright spot seen in T1 sagittal section. And similar hyperintensity is also noted in a T2 section. It was thought of an RCC, or it could be an apoplexy. This is a dynamic contrast imaging of the patient. It revealed a heterogeneous uptake after the contrast. And this is a T1 sagittal image showing a pseudocapsule appearance. So it was thought whether it could be an adenoma or a hypoplasia. Whenever a patient presents with high TSH levels, generally more than 100 with pituitary cellular lesion, it favors a hypoplasia. And this patient also had a TSH of more than 100, and it was favoring, and it has a dome-shaped elevation. There was a heterogeneous uptake in the cella which is favoring an adenoma, and there was a presence of a pseudocapsule which was favoring an adenoma, and there was a presence of doubtful apoplexy like lesion and which was favoring an adenoma. It could be an RCC also, and the lesion was a dome shaped and smooth upper border, often described as nipple sign, and it was there, and there was no paracellular invasion or any other access hyper deficiency or hypersecretions which favor hyperplasia, but the adenoma can have those things. This is a follow-up image of the patient, ma'am. So this is after 3 months, recently done 2 weeks ago, and the TSH was 0.46 micro IU per ml at the time of the scan, and the lesion showed no decrease in size of the lesion. This is only a baseline image, no contrast was done. So the lesion is in a T1 coronal section. It's 16.3 millimeter, and it was same as the previous previous study, ma'am. So the lesion didn't show any, at least a little sign of regression. So a final diagnosis of pituitary non-functioning macroadenoma with coexisting pituitary primary hypothyroidism was made for this patient, ma'am. The patient doesn't have any visual complaints, so the patient is still under follow-up only. Visual complaints are any raised ICT signs, so patient is still under follow-up only, ma'am. So after 3 months, we might repeat another scan again and see for what happens, ma'am.
So your final diagnosis is macroadenoma.
Yes, ma'am. Yes, ma'am.
Why do you want to wait for the treatment? This patient, macroadenoma, you think it's likely to recede in 3 months?
No, ma'am. As a patient doesn't have any signs of raised ICT or any visual field defects now, and the patient, like sometimes like hyperplasia is also shown to regress after 6 months till 6 months to 1 year, ma'am. So just wanted to be sure, ma'am, since the patient is comfortable on follow-up for the time being.
Because it seems to be encasing the cavernous sinus. So I don't know whether waiting might be you need to consider a neurosurgical opinion.
Yes, we have sent for neurosurgical opinion also.
Okay, over to you, ma'am.
So I think we can have the quiz questions, answers now. So Dr. Altamash will tell us the answers and then he'll announce the winners as well.
Sure, ma'am. I'm yet to receive the results also.
Yeah.
You go ahead with the answers.
You will receive, yeah.
Yes. Slide clear?
Yeah.
So incidence of question 1, incidence of thyroid carcinoma with insulin resistance. The incidence is high. So anybody with a small tummy, big tummy, you have insulin resistance, you have acanthosis, you have tags, you are overweight, your incidence of a thyroid carcinoma is high. It's a very latest 2021 meta-analysis done across the world. Question 2. This patient actually presented as acromegaly, was seen by surgeons, neurosurgery, various departments. There was a pituitary adenoma over there, but it was the TSH which was measured with different kind of lab error. And when the TSH was repeated in different labs on third or fourth occasion, it was a high TSH. So it was the insulin resistance and a pseudoacromegaly type of a picture in this. And this is one of the first cases presented from India in Pituitary 2011. Pseudoacromegaly as one of the primary presentations of primary hypothyroidism. So euthermia, of course, is out over here. The race, age, and obesity are the factors which can influence obesity. False is that, yes, you would actually stop the antithyroid drugs if the symptoms are of drug-induced neutropenia is over there. It was an easy question. This is a photo taken from Mangalore, and this is a coffee plant. These are the coffee beans, and we know that espresso coffee does have an effect along with the thyroid function tests. False about food in the diet. The goitrogens are inactivated by heating and cooking. That's the reason the cabbage and soya bean can be eaten with hypothyroid people if it is cooked, unless against the popular myth that they should not be eating unless there is a coexisting iodine deficiency also. Liquid thyroxine formulation, they have equivalent dose weight-based dosing, and that's why they are more precisely dosed for the infant, even when given with milk. So that is their advantage. False statement. Here, in children and adolescents, DTC is responsible for 95%, which is right, but it is papillary thyroid carcinoma, which is accountable for 90% of cases, easy one. This is a normal thyroid tissue. The usual tendency is that something follicular is there. I think it was a very, very basic one to talk about, that these are the normal follicles containing colloid, normal parafollicular C cells and follicular cells. Not a potential sign or symptom of thyroid cancer. Persistent cough, yes. Hoarseness of voice all the time, yes, which does not go away with treatment. Here the twist was raw throat not relieved by routine treatment, and hoarseness that goes away with routine treatment. I think that I complete my answers. Due to lack of time, I think I would suggest to let's announce the winners.
Yeah, you have to announce.
I have to announce.
Yes.
It's there. So Dr. Nanda N, and that's the first prize. I understand that since it's written over there that way. Dr. Sagar Saurabh stands second for the quiz, and Dr. Anis Joseph stands at the third position. Congratulations to everybody, and thank you all the faculty for having me over here. And thank you, madam, for calling me and inviting me. Thank you so much, Indian Thyroid Society.
So I think with this, we come to the end of today's thyroid clinic, and we had a really nice discussion starting from the cases on thyroid. And we know that there were some controversial issues which were discussed today, like when the children present with hypothyroidism and it is long-standing. So there are two schools of thoughts, but we know that that data is very sparse. So we don't still have clear-cut guidelines, but most of the people do want to start with the full dose. But there are some schools of thought where people want to start with a slow dose and then go up. So these are all two schools of thought. But if you see the ATA guidelines, they have not mentioned anything about the slow starting, but we do have controversy because there are some case reports on that. Coming to the next, we also discussed about the next case where we discussed about the high prolactin values, which can be seen in patients with hypothyroidism. And all these are things, but we also have to remember that whenever the prolactin is high, it's the drugs which we have to definitely rule out before we think about any other cause, and definitely thyroid disorders and renal disorders and liver disorders, which can be the incriminating factors. And not to forget the breast examination, if it has been done, the sleep, it is not appropriate, or patient hasn't slept properly, patient is stressed out, all these factors can lead. And so we have to be very cautious before interpreting any high prolactin and labeling the patient as prolactinoma, or going in even for a pituitary MRI, which may not be required for many of these patients. Then we had a very interesting case discussion on the metastases, pituitary metastases. And as we discussed, that these follicular thyroid cancers can have mets, and we have to be aggressive with the treatment because the survival may be shorter. And if we are not aggressive, and we discussed that we have to be cautious about the things which have been done before we go in for the radioiodine scans, not only thinking about the recombinant TSH in these patients who are secondary hypothyroid, but also to think about the contrast, like Dr. Vaishali rightly pointed out 4 to 6 weeks back. If it had been given any iodinated contrast, it can change the results. And then obviously we had a follow-up of the case discussion, which we did before. And the quiz was really interesting. We thank Dr. Altamash for such an interesting quiz, and the students actually like it. And all my students, they wait for this quiz every time. So it's nice to be a part of this. And I hand it over to Sarita Bajaj ma'am to give her final comments on this.
So thank you, Pramila. So I think this has been one of the most interesting thyroid clinics, with a vast array of patients. It's not just been 2 cases. We've had a wide array of cases, from cretinism to juvenile hypothyroidism to pericardial effusion to the interesting signs with videos which have been demonstrated by Sumaya, thanks to Rakesh. It's coming from Osmania. I think and of course, Dr. Batra informed me about this case maybe I think 3 months ago. And he said, no, this must be presented. I said, absolutely. So just waiting for the right opportunity. And I think Vaishali has discussed it brilliantly. Thank you, Vaishali, for bringing out all those valuable points. And what you said about the tumor board, I think that is a very, very important take-home message. And dynamic TNM staging. So all these are extremely relevant. I think Dr. Batra's point was noteworthy, that one of the cases we saw, that cretinism is something I pray that we never, ever, ever get to see. It's extremely unlikely. It should not be the case in this day and age. It makes you feel that, like we are missing something. We're not being, we're not able to perform adequately. Like you feel there's something wrong on the part of the endocrinologist. But I think that's part of the game. So we had Rakesh chairing. I think that was great. Dr. Batra moderating, Vaishali moderating, and both the residents did a wonderful job, Sumaya and Varsha as well. And thank you. I think that case was a dilemma when Sidhu presented it. It was, I think, a little over a month back, but I think that has been, for the time being, been sorted out. And what Vaishali rightly said, how should we proceed once it is a macroadenoma? I think that question has been addressed as well. So we have, of course, thank you, Pramila. Thank you for being with us for every meeting and, like bringing out all the important points. Arun, I think, is in the background. Mini is also with us. They are part of the scientific board. Congratulations to the quiz winners. Altamash, that was a wonderful quiz. That was a wonderful quiz. I think that takes more time to prepare a quiz, I think, than to prepare a regular talk. Thank you very much. So this is the next session, which will be because of the sharer. So it will be a little later than anticipated. It will be 19th October. We'll be sharing all the details, but they are displayed here for you here. We have an excellent session in collaboration with ISBMR, because 20th is World Osteoporosis Day. This was Dr. Usha Sriram's idea. So we are combining ITS with ISBMR and coming up with a nice program, and monologue by Dr. Nihal Thomas, quiz by Dr. Somik Goswami. So thank you everyone for being here. From the digital team, we have Asmita and we have Medisage Priyanka. Thank you all for joining us. I think Dr. Prasanna had also joined in, but I'm not sure if he's still around. Thank you everyone.
Thank you, ma'am.
Thank you, ma'am. Good night.
Thank you, ma'am.
Good night. Good night.
Okay. Thanks, everyone.
Bye-bye.
Thank you, ma'am.
Good night.
Good night.